Good evening, and welcome to the second Florida Orthopedic Institute live lecture. Thank you for joining us. My name is Hannah Vargo, and I'm a physician liaison at Florida Orthopedic Institute. Tonight, I'm proud to present Dr. Jeff Kannen, one of our primary care sports medicine doctors. He'll be talking about bone health, osteoporosis, and its treatments. Dr. Kannen is board certified by the American Board of Family Medicine. He's a member of numerous organizations, including the American Medical Society for Sports Medicine, the American College of Sports Medicine, and the American Academy of Family Physicians. Dr. Kannen cares for all musculoskeletal conditions in pediatric and adult populations. He has special interests in overuse injuries and upper and lower extremities, endurance sports injuries, diagnostic ultrasounds, and regenerative medicine treatments. Before we get started, just a few housekeeping notes. First, we'll be sending everybody a link to the webinar. Second, you can comment or ask questions directly on Zoom. I'll be monitoring those questions. You can also send questions to our Instagram or our Twitter at FL_ortho. Third, if you don't have a sound or your slides are not moving, please try refreshing your browser. With that, I'm pleased to turn it over to our speaker, Dr. Jeff Kannen.
Thank you, Hannah, for that introduction. Thank you and welcome everyone tonight for today's live lecture for bone health. I have no disclosures for this presentation tonight. So our objectives tonight, we're going to review key topics in bone health. We're also going to review concepts of fracture risk assessments in the population, as well as different treatment options for low bone density and osteoporosis. First, we're going to start with an introduction to bone health and what that means. So bone health plays a critical role in maintaining a high level of function within the body. So bones are very important for maintaining different aspects of your function in day-to-day life. Certain imbalances within the body can lead to poor bone health, and you can develop osteoporosis or low bone density from these imbalances. And this increases the risk of having a fracture. Traditionally, with bone health, we've tried to target the older populations because these are more at risk traditionally. But there's been a trend more recently with screening younger and younger people because we found that there's also a risk in younger people for having low bone density. And this may include younger populations with certain diseases, as well as athletes. So what is osteoporosis? Well, it's a major health issue, and it seems to be underdiagnosed and undertreated in the general population, and that's why we're going to focus on that tonight. The aging population in the United States is generally getting older, and this is contributing to an increased population that is going to have low bone density. And that's why it's very important to focus on this population. So osteoporosis is preventable and it is treatable, but only about 1 in 4 people, or a quarter of the population that has low bone density, is either treated or even diagnosed, and that's a pretty small number. Many patients who have a fracture, and what I'm talking about is a fragility fracture, and that's a fracture secondary to low bone density. Many of these patients aren't treated or they're not assessed for having a low bone density. Next, we're going to talk about kind of bone structure and how bones are important for the function in the body. So when we're looking at a bone, this is an example of a long bone, and this is how most bones are in the body. There's different types of bones within the body. Traditionally, when we're looking at a bone, we have different parts of the bone. You have the outer portion of the bone, which we call the cortex or the cortical surface. And that's kind of the outside hardened layer of the bone. And then within the bone, there's this inner layer, and we call that spongy bone or medullary bone. And this bone is important kind of for the whole structure of the bone. And this inner portion of the bone is most affected by low bone density. And this is where you can develop osteopenia, which is a low bone density, or osteoporosis. And generally that occurs within the shaft of the bone, like here we can see. And then there's different parts. You have the ends of the bone, which makes up the articular surface, and that's the point that goes into the joints. And then you have other different aspects of the bone as well. And that's kind of the primary structure of bones. So what do bones do? They provide the structure to the body. They help protect the organs within the body. They're an area for mineral storage within the body, specifically calcium and phosphorus. Those are the major minerals within bones that are important. Another thing they do is they produce red blood cells within that inner portion of the bone. And that's very important for providing red blood cells within the body. And those are the kind of the major functions of bone within our bodies. So what does low bone density mean? We're going to talk about that next. So the major kind of disease affecting low bone density is called osteoporosis. And this is a disease process within the body where bones start to lose their density, and this makes them very brittle. It makes them at an increased risk for having a fracture or breaking. Osteoporosis is characterized by an imbalance of bone formation as well as bone breakdown. And most people up until older ages tend to not have a significant imbalance in their bone unless you have certain underlying diseases. And then what happens in low bone density or osteoporosis is you get an increased bone breakdown, and that leads to lower bone density. So osteoporosis, you can see in this figure on the top portion, this is what normal bone looks like, and this is a figure for that. So you have this nice kind of structure within the bone here. And then in osteoporosis, which is lower, you can see that you develop these bigger gaps within the bone, and that's what happens when the bone starts to lose its density. And so it's not as strong, and you get not as much structure within it, and that makes it an increased risk for breaking. So what is osteopenia? Osteopenia and osteoporosis are similar disease states. Osteopenia is kind of a less severe form of osteoporosis. We consider it low bone density, but it's very important to note that it still carries an increased risk of having a fracture. So it's very important, even if you have osteopenia, that you still manage and treat that. Osteopenia may progress to osteoporosis as well. So in the United States, about 10 million people have osteoporosis, and they're diagnosed each year. About 40 million Americans will have osteopenia, and that's a pretty significant number. And like I said earlier, only about 1 in 4 of these is actually diagnosed or treated. So there's many people out there in the general population who are not being treated for this. And about 1.5 to 2 million Americans will have fractures secondary to osteoporosis each year. And that's a fairly significant number. So a question I often get is osteoporosis similar to osteoarthritis? And these are actually 2 different disease states. So osteoporosis affects low bone density, and it decreases the density of the bone, whereas osteoarthritis affects the joints, and those are the areas on the ends of the bone. And these are completely separate. They're not caused by the same thing. And it's important to know that distinction whenever you're being treated or seeing your doctor so that you can ask about that. So next, we're going to talk about certain fractures, and we're going to kind of overview some of the fractures that can be related to osteoporosis. And there's 3 main ones that we're going to talk about now. Most severe is a hip fracture. Then you can also have a spine fracture or vertebral fracture. And then you can also develop a wrist fracture. And these are the 3 most common fractures related to low bone density. Hip fracture, so like I said, This is kind of the more severe one that we focus most of our attention on in order to prevent and treat. About 300 people each year in the United States will develop a hip fracture. Most of these occur after a fall, and this can be a fall if you're standing or if you slip and fall. And most of these occur in elderly patients older than 65. You can also develop a hip fracture if you have certain disease states, or you can develop it in a young person who has a more major injury, such as a car accident or a fall off of a ladder. Hip fractures carry a significant risk of complications. The most important things and complications that we focus on are you're at risk for developing a blood clot, you can get lung infections and pneumonia, you can get muscle wasting from being bedridden, and then it also increases the risk of death, and that's very important because there's an increased risk of death associated with hip fractures. So we want to be able to avoid that if possible. Most of these hip fractures occur in kind of in a certain area within the hip. So here on the right here, we have a picture of the hip, and you have a certain part of the hip. You have the femoral head where the joint connects. Then you have the neck, which attaches the rest of the bone in the thigh called the femur. And most of these fractures occur either in the femoral neck or this inner trochanteric area. And it causes the hip to be very unstable. Most patients aren't able to walk on a broken hip, and they usually require hospitalization and surgery to fix. The next type of fracture that we're going to talk about is what's called a spine fracture or a vertebral compression fracture. These are actually the most common fracture out there related to low bone density and osteoporosis. Up to about half of people over age 80 years old will develop a vertebral fracture. And that's a very significant number when you think about that. Most of these occur kind of in the lower area of the spine, called the lumbar spine. And they can also occur up in the upper portion of the spine, which is called the thoracic spine. Risk factors for these are low bone density, having a fall, either from a standing height or slipping on an object, or if you have a history of a vertebral fracture, that'll also increase your risk for having another fracture. Most of these are treated on trying to control the pain, as well as restoring their function with day-to-day activities, and then treating their osteoporosis. The next fracture we're going to talk about is a wrist fracture. And these are most commonly in younger patients, usually right around menopause in females or postmenopausal female. And menopause is right around the age of 50. So usually we see these, right around the age of 50 or older. And these occur after a fall, typically. When you look at the wrist, most of these occur at the distal radius, which is one of the bones in the wrist. You also have the ulna, which is the second bone in the wrist. And usually the treatment will involve either a splint or cast for about 6 or 8 weeks. Or sometimes if the fracture is unstable, you'll require surgery. So why do we worry about fractures? Well, there's several different adverse consequences to having a fracture. It may involve an admission to the hospital or a nursing home. You'll have increased pain and decreased function at the site of the fracture or above and below. You might have more complications related to your hospitalization or with the rehab afterward. And this puts a greater burden on patients as well as their families and caregivers. And these are the most significant adverse effects of fractures. So when we're looking at bone density, we want to kind of talk about risk factors for having low bone density. So next, we're going to talk about certain things that you may have or certain things that you can modify that may increase your risk of having a fracture. So the biggest ones that we're going to talk about are having tobacco use, drinking alcohol, and that's excess alcohol more than the recommended limit per day, not exercising or getting regular exercise. There's a population that's at risk for having a fracture or low bone density, and that's Caucasian females and usually of a European descent. Having a lower body weight, as well as not eating enough protein in your diet, will increase the risk of having low bone density. Having premature menopause as well. Certain athletes, such as long distance runners, and those tend to be a little bit leaner and low body weight. That'll increase your risk of having low bone density, as well as certain sleep disorders. Certain medicines may increase the risk of having low bone density. This is a list here of the most common ones that are related to having bone density. Phenytoin is one. Certain treatments for cancer may increase the risk of osteoporosis. Being on certain antidepressants or SSRIs, being on long-term antiviral therapy for HIV or AIDS may increase the risk of low bone density. Being on Lasix or cyclosporin. Methotrexate, which is used to treat rheumatoid arthritis, may increase the risk for having low bone density. Certain thyroid medicines may increase the risk. Being on omeprazole or medicines to treat acid reflux may increase the risk, as well as oral steroids for a prolonged time. If you're on heparin, which is a blood thinner, that may also increase the risk. Having certain diseases may increase the risk of having low bone density. Liver disease, hyperthyroidism, having diabetes, specifically type 1 diabetes. Having certain cancers may increase the risk, and that's usually related to the treatments. Having end-stage kidney disease or renal disease, COPD, rheumatoid arthritis has been related to low bone density. Having sarcoidosis, which is an autoimmune disease which targets the lungs as well as other parts of the body. And then in athletes, having what's called relative energy deficiency, which is not a very common topic, and I'm not going to address that very much today, but it's important to know that if you have an athlete who has low bone density, then they might be at risk for having osteoporosis. So how do we screen you for osteoporosis? There's two main ways. One is performing what's called a bone mineral density test, and this is also known as a DEXA scan. We're going to talk about this a little bit. This is typically a test that's done to screen patients, and we'll talk about certain guidelines that can be used to screen patients. Once you have a screening test and that test is normal, we typically don't repeat that test unless you develop risk factors or have a fracture in the future that might be related to bone density. Then we might test you again. So what do we use screening for? It's used to screen patients who are at higher risk for having a disease within the population. And there's not a universal guideline. There's several different organizations who have developed guidelines. And some of these use the same criteria and some are a little bit different. And I'm going to go over kind of the guidelines that I usually recommend for patients. So in terms of screening, typically we recommend all women greater than the age of 65 to be screened for osteoporosis. If you're postmenopausal and a female and you have certain risk factors that might increase your risk. And these are several risk factors here listed. If you have a history of a fragility fracture, and that's one of those 3 fractures that I mentioned, the hip fracture, spine fracture, or wrist fracture, and you're between the age of 40 and 45, you might want to consider being screened for osteoporosis. If you've had osteopenia or osteoporosis identified on an X-ray, then that's another reason you should have a bone density test. If you've been on long-term oral steroids, and that's usually greater than 3 months, and that's usually typically every day, then you'd want to be screened for osteoporosis. And then if you have rheumatoid arthritis, that's another reason to be screened. The third criteria here is usually a woman who's right around menopause or postmenopausal with certain risk factors. If you're a current smoker, if you drink more than 2 drinks of alcohol per day, if you have a family history of having an osteoporotic fracture, then you want to get screened. If you've had early menopause or if you have low body weight, you might want to consider being screened for osteoporosis. So how do we diagnose osteoporosis? So before we talked about screening, which is used to identify people who might be high risk. Now we want to diagnose osteoporosis. And like I said, this is done with a bone mineral density test or a DEXA scan. And that's the most common way that we diagnose you with osteoporosis. The second way is if you've had a fragility fracture, and that's one of those 3 fractures that I mentioned, a hip fracture, a vertebral fracture, or a wrist fracture, then regardless of your bone density test results, then we automatically typically diagnose you with osteoporosis. So next I'm going to talk about what a bone mineral density test is. So kind of the medical term for this is a dual energy X-ray absorptiometry, or a DEXA scan is the most common phrase we use. And it's a very simple test. It's usually performed at an imaging facility. It's an outpatient. It's very non-invasive. It typically uses kind of 2 X-ray waves, and it scans the body here. So on this picture, you can see we have a gentleman here laying on this table, and this kind of bar above him will move across his body, and it's going to measure his bone density by using these low energy X-ray waves. So once we perform this test, we get certain results. And the most common result we get is what's called a T-score. And this T-score compares the results of an individual patient to that of a 30-year-old healthy person in the population. The lower your T-score, the lower your bone density is, and the more at risk you're having for either osteopenia or osteoporosis. There's another kind of result that will show up typically on some bone density tests, and that's called a Z-score. We don't use this too often. It's usually more in pediatric populations or younger patients. And this compares your result or an individual's result to that of a person of the same age and body composition. And that's usually the same kind of height or the same weight. So when we're looking at the results, so typically a T-score of -1 or higher is considered normal. If you have a T-score of -1 to -2.5, that's considered low bone density or osteopenia. And then if your T-score is less than 2.5, we consider this osteoporosis. And those are the typical numbers that we use, and these do not change. So once we get your bone density test, or regardless of a bone density test results, we can use what's called a fracture risk assessment. And this helps us also determine if you're at high risk for having a fracture. So your bone mineral density test may be used to calculate this risk score. It considers and it estimates the risk of having a fracture in the next 10 years. And this is a general estimate. It's not completely accurate, but it's very, very good. And it can help us determine kind of your risk, and it can help us determine the right type of treatment for you. We recommend typically treatment if your hip fracture risk is greater than or equal to 3%, or if your major osteoporotic fracture risk, and that's that fracture that's either a hip fracture, a vertebral fracture, or a wrist fracture is greater than 20%. And that's within the next 10 years. So how do we monitor your risk of having a fracture? Well, once you have a bone density test performed and you're diagnosed with either low bone density or osteoporosis, you typically want to repeat the test every 2 to 5 years, depending on your treatment as well as your decision with your doctor. And regardless of changes in your bone mineral density test results, you will still want to continue treatment regardless of those results. So if your results improve, you'll still want to continue on your treatment that you've been on. And you'll want to talk to your doctor about kind of when you would continue that and when you would stop. So next, we're going to talk about treatment options for osteoporosis. So the goals of treatment, there's really one main goal. It's to reduce the risk of having a major fracture, and that's having a hip fracture, a vertebral fracture, or a wrist fracture. And then kind of a secondary goal is to prevent, stop, and reverse the disease. Because once you have osteoporosis, you may be at risk for having further fractures. So kind of the approach that I use and most clinicians will use in terms of preventing and treatment of osteoporosis is kind of a multi-component approach. Typically, we'll focus on weight-bearing exercise and falls prevention. We'll focus on tobacco and alcohol cessation. You'll want to supplement with certain vitamins, such as calcium and vitamin D. And then you might want to consider certain prescription medicines to treat the low bone density. So next, we're going to talk about kind of what weight-bearing exercise is and how this is important for the treatment of osteoporosis. So why do we talk about exercise and why is that important for osteoporosis? Well, we found that kind of exercise will affect the bones, and the more that you're exercising and putting weight, that changes the density of the bones, and that can be very effective in either preventing or maintaining your bone density. So usually we recommend a multi-component program that uses weight-bearing exercise or balance training in most patients. You'll want to avoid strictly aerobic exercise, and you'll want to incorporate certain resistance exercise or balance training. And that's been shown to help the most with low bone density. So what are some examples of certain exercises that you can do to help with your low bone density? So we'll talk about aerobic exercise. And that's more of kind of cardio exercises. So you can do things like walking, jogging, or hiking. You can do step aerobics. You can do racket sports such as tennis, which is more dynamic. You can use a stair climber. You can do dance exercises. Then you can also use an elliptical if you have access to a gym. And typically you'd want to aim for about 30 minutes of this type of exercise, about 4 or 5 times a week if you're able to. And that will give you the most benefit for your bone health. Next exercise you'll want to consider doing is resistance exercise, and that's weight-bearing resistance exercise. And some examples of this are doing certain body weight exercises, such as push-ups, squats, or lunges, using free weights. Using elastic exercise bands can be very effective. Using certain weight machines where you're putting weight on can be very effective. And you typically want to aim for resistance exercise about 2 or 3 times per week if you're able to. The next thing that we'll focus on is what's called falls prevention. And falls are kind of more directly related to having a fracture than bone density test results. And that's very important to kind of recognize, because even if you have low bone density and you're having frequent falls or frequent accidents, that will increase your risk of having a fracture significantly. And we typically recommend certain weight-bearing exercises. You can do physical therapy and then supplementation with vitamin D and calcium. Patients who are at risk or older will be able to help with falls prevention. So certain things that you can do around your home or for a family member to help kind of make your home safe would be to remove obstacles around your house, which may increase your risk of having a fall. You'd want to wear supportive footwear. You want to avoid walking barefoot or having a kind of a, I guess, a kind of a surface that makes it more increased risk of having a fall. You'd want to use rubber mats in your shower because that will help with gripping. You'd want to avoid using rugs on a hard floor. And that's because the rugs can slip easily unless you have something underneath the rug to hold them down. Then they might slip and they can increase the risk of having a fall. You'd want to consider installing handles around your bath or shower, and that can be helpful. And then you'd want to consider using a cane or a walker if you need to in order to help with your balance. So the next thing we'll talk about is treatment with supplements. So really two main supplements that would be used in having low bone density is calcium and vitamin D. And most people want to aim for about 1,200 to 1,500 milligrams of calcium per day. You want to aim for about 800 international units of vitamin D per day. And these numbers will vary depending on your risk and your certain situation. Sometimes we'll test you for having calcium or vitamin D, and that's a blood test that we would perform. And most patients would want to supplement each day with these vitamins. You'd want to consider this in a younger patient who might be at risk as well. Some examples of calcium and vitamin D intake in your daily diet would be foods that are high in dairy. So that's such as milk or cheese. Certain yogurts will be high in calcium. And then certain vegetables such as broccoli or bok choy or almonds. Those are some examples of foods that are high in calcium. So next we're going to talk about prescription treatments for low bone density and osteoporosis. So who needs kind of prescription treatment? I get this question a lot. A lot of times we'll focus on those other preventative measures such as weight-bearing exercise and supplementation. But sometimes you'll want to consider using prescription treatments. Typically patients who've had a history of having a fracture, such as a hip fracture or spinal fracture, will want to consider being treated just because your risk of having another fracture in the future is very high. If you've had osteoporosis confirmed by a bone mineral density test, you'll want to consider being treated. If your total fracture score is greater than 20% or your hip fracture risk is greater than 3%, and that's in the next 10 years, then you'll want to consider being treated. If you're high risk for falls, despite your low bone density test results, you'll want to be treated. And then if you've had a fracture and you're on long-term steroids for a certain disease, then you'd want to consider being treated because the steroids will increase the risk of having low bone density. So there's really two main classes of prescription treatments. I'm going to touch on primarily this first class, which is called the anti-resorptive class, and these are the most common. And what these do is they prevent new bone loss within the bones themselves. The second class, and these are less commonly used, these are called anabolic medicines, and these tend to build up new bone within the body. So the anti-resorptive medicines that we typically use, and these are all approved for use in low bone density and osteoporosis. The most common is what's called bisphosphonates. The second most common would be Donosumab. Then you have estrogen hormone therapies. You have a medicine called Raloxifene, and then you have this combination medicine below with estrogen. So the first class that we're going to talk about is called bisphosphonates, and these are first-line treatment for osteoporosis. They're recommended in patients who are diagnosed with osteoporosis or at high risk for having a fracture. And these basically target cells that break down bone, and that's how they work. And it reduces your risk of having a hip fracture or spinal fracture by about 50 to 90%, and that's a very significant number. These are taken either daily or weekly. Most commonly, I would prescribe this weekly. And usually you'd want to be on the treatment for approximately 5 years. Some patients will want to take it longer. And if you're unable to tolerate this by mouth or a pill, sometimes you can take it by an IV form. And that's not very commonly done. The most common formulations used in this class, you have alendronate, risedronate, you have abandronate. Those are the most common forms. And then you have several others here. Typically, you'll want to take these on an empty stomach first thing in the morning. You'll want to avoid using in certain chronic kidney diseases, as well as if you have certain esophageal disorders. Some of the adverse effects of these are they can cause joint and bone pains. It can irritate the lining of the stomach and esophagus, which is your food pipe. It can cause atypical femur fractures, and it can also cause what's called an osteonecrosis of the jaw. I wanted to talk about osteonecrosis of the jaw because this is a kind of a question I get a lot from patients regarding the side effect. This is a rare adverse consequence of having oral bisphosphonate or IV bisphosphonate therapy. And nearly all the cases of having this occurred in patients who are on IV doses and high doses of oral bisphosphonates that were being treated for cancer-related osteoporosis. And usually the risk of having this is extremely low if you're going to be on oral therapy. And I usually recommend talking with your doctor about this risk. And typically the risk is very low and the benefit of being on the treatment would outweigh the risk of having this. The next treatment we're going to talk about is called Donosumab, and this is another first-line treatment. It's recommended for patients who have been diagnosed with osteoporosis or have high risk for having a fracture. And again, this helps target cells within bone that break down bone. And by that way, it kind of increases the bone density. And this will increase the risk pretty similar to the other therapy I talked about with oral bisphosphonates. It'll decrease the risk of having a fracture by 40 to 70%, and that's very significant. This is given every 6 months. It's used as a subcutaneous injection, which goes under the skin. We'll typically give this in the office, but some patients can take this at home if they've been instructed. You'll want to check your calcium level as well as your kidney function prior to administering this, because it may decrease your level of calcium within the blood. Or if you're at risk for having low calcium, you may want to avoid this medicine. And typically, once you start this medicine, you'd stay on this for the rest of your life or indefinitely. Some patients may consider coming off of it, and then you should consider switching to another medicine, because once you stop this medicine, your risk of having a fracture will go up again. The two main forms that are approved are called Prolia and Xgeva. The next treatment, and I'm going to briefly talk about this, and this is called estrogen hormone therapy. This isn't a very common therapy used. Typically, we'd use this only in kind of postmenopausal or menopausal women who are having hot flashes or symptoms secondary to menopause. And I typically don't recommend using this in older patients because it can increase the risk of having a heart attack or a stroke. It'll increase the risk of having a blood clot, as well as certain breast cancers within the body. And it's not a treatment that I typically would recommend in an older patient, usually greater than 60 or 65. The next treatment, and this is called Raloxifene or Evista for the name brand. This is not a first-line treatment. It's another treatment that targets estrogen or hormone receptors, and it helps decrease bone turnover within the body. And it's used in prevention of vertebral fractures only. This will also increase the risk of having a blood clot in certain breast cancers. The next is a combination treatment, and this is Bazedoxifene and estrogen. The brand name is Duavee. And this is a newer treatment, and it's a combination treatment that's not a first-line treatment used. And this also targets estrogen or hormone receptors within cells. And it's used only in the prevention of vertebral fractures. It will not decrease the risk of having a hip fracture or a wrist fracture. This one also increases the risk of having a blood clot, as well as a heart attack or stroke. The next class that I'll briefly talk about, and these are the anabolic medicines, and these are medicines that build up new bone. The most common that we use is called Teriparatide or Forteo. And this is not a first-line treatment. What this is it's a synthetic form of what's called parathyroid hormone. And this is a hormone or chemical made within our own bodies. And this can stimulate new bone growth. So the concept of this is that if you give this medicine, then it can stimulate your bones to increase their density and make new bone. And this is used in men or women, and it will reduce the risk of having a hip fracture or a vertebral fracture. Typically, we give this every day, and it's given under the skin as an injection, and you'll typically stay on the treatment for about 2 years. The next treatment, and this is again not a first-line treatment, is called Abaloparatide or Tymlos. And the mechanism, again, this is a synthetic parathyroid hormone, helps stimulate new bone growth. And this is also used in men or women, and it reduces the risk of having a hip fracture or a vertebral fracture. And again, just like the previous medicine, this is given once daily under the skin as an injection. And you'll typically be on this medicine for about 2 years. The last medicine that we'll talk about, and this is a newer treatment, this is called Romosozumab or Evenia. Again, this is not a first-line treatment that's available. This inhibits a certain protein within bone cells, and it helps stimulate new bone growth by kind of blocking this protein. And this reduces the risk of having a vertebral fracture or spinal fracture about 50 to 75%. And this is given monthly as an injection for about 12 to 24 months. So just to kind of summarize about these concepts that we talked about. So what can you do to help with your bone density? First, you'd want to educate yourself. So listening to this lecture and talking with your doctor is a great way to educate yourself about low bone density and if you're at risk for having low bone density or need treatment. You'd want to get tested for low bone density, and that's with a bone density test. You'd want to limit your alcohol and tobacco use. You'd want to safeguard your home, and that's with those kind of preventative measures that I mentioned earlier. And then you'd want to really focus on exercise, and that's weight-bearing exercise, in order to reduce your risk of having a fracture. So what treatments do we offer here at Florida Orthopedic Institute? Typically, you'd be treated for your primary fracture if you sustain a fracture, and that's either a hip fracture, a vertebral fracture, or a wrist fracture. And then you could consider having a consultation with a bone health specialist. And what that involves would be a fracture risk assessment. We may test your low bone density with a mineral bone density test. We might test your blood for calcium or vitamin D. We might refer you to a physical therapist for a falls prevention program to work on your balance, as well as discuss an exercise program that you can do on your own. And then we'll also use prescription treatments in the office. And the most common ones that I'll usually use are the oral bisphosphonates or Prolia, which is an injection. And those are the most common ones that we'll use in the office. And then at this time, we're going to conclude our lecture tonight, and we're going to open the floor to some questions.
That was excellent, Dr. Kannen. Thank you. Very informative for anybody suffering from osteoporosis. We do have a couple questions. They were coming through. We actually have quite a few. We'll start with, should weights be worn on the ankle while you're walking?
That's a good question. Typically, you don't need weights on your ankles in order to get benefits of walking, which is a great exercise for low bone density and preventing low bone density. If you want to add an extra little weight, that can be helpful to help increase in your muscle mass or your strength in your legs or your hips. So, if you want to consider doing that, then you can definitely do that.
And I know that you had touched on it before. However, if we could reiterate, how much vitamin D is good? And is that going the same for women over 65?
Right. So typically you want to aim for about 800 units, and that's international units of vitamin D per day. Most people will get that in their diet. You can use a supplement for that as well.
Excellent. Thank you. We have a few more. Do you recommend against a vegetarian or vegan diet if somebody has already been diagnosed with osteopenia?
Right. So if you're on a vegan or vegetarian diet, you'd want to make sure that you supplement with calcium or eat vegetables that are rich in calcium. That be broccoli, usually green leafy vegetables, and most patients who are either vegetarian or vegan will be using those.
Excellent. And a couple more yet. What do you think about using Fosamax before or after a hip replacement surgery? Should the patient stop for a while before or after surgery?
Right. So typically you wouldn't start before surgery. You'd want to, be treated in the hospital or by your doctor for your hip fracture. And then you'd start it usually after your surgery.
Okay, perfect. And two more yet. What about foot fractures with no fall or injury prior? As important as hip, wrist, spine towards diagnosis or not?
Yeah, so that's a good question. A certain hip fracture that might be at risk or kind of increase your risk would be having a stress fracture in the foot. And usually it's due to overuse or putting a lot of weight or repetitive activity, such as walking or running. And some patients might have low bone density and not even know it. So you might want to talk with your doctor or be screened for having low bone density if you do have a foot fracture.
Okay, and this one kind of goes hand in hand. It's our last one to wrap it up. When I was in my teens, I broke a few bones in a bad accident. Although I don't look a day over 25, I am over 65. Do those previous injuries from so long ago put me at a higher risk?
Typically not, unless you have a certain disease and you're diagnosed at an early age, such as like rheumatoid arthritis, or if you've been on long-term steroids, then you might want to be screened for having low bone density. But typically, if you've had a fracture and you're young and it was due to a trauma or an accident, we typically wouldn't screen you unless you reach the age that we typically recommend screening.
Great. Dr. Kannen, that was an excellent presentation. We thank you and we thank everybody for joining us. Enjoy your evening tonight. Have a good one.